first in-person event for TAG Digital Health in over 18 months. We're excited to all see a bunch of faces here. And for those of you that are joining us virtually, welcome. This is the 5th of 7 digital health events that we are having this year. For those of you new to TAG Digital Health, we're one of 23 different societies here in TAG. We happen to be one of the most active societies. We represent digital health concerns across all of Georgia, bringing spotlight and awareness to digital health concerns at the regional, national, and obviously over the past 18 months, global level. Digital health in Georgia represents one of the 6 major economic clusters with over 44,000 employees here in Georgia, 210 companies, about $12 billion in revenue in digital health here in Georgia. We're proud to say that digital health, the Digital Health Society was with everything that occurred last year with COVID, we were the first to pivot to a virtual meeting agenda. And so we immediately pivoted to the virtual agenda, the virtual format. We're immediately able to get up and running and continue on a path for being able to meet virtually. We held a summit in November that was resounding success. We had a number of different folks from around the country that were participating. So can't give enough credit to the folks that held that. And now here we are 18 months later, and we're having our first hybrid event. So we happen to be one of the first society sponsors that is that's going to be doing an in-person event as well. Quick blurb on the next slide.
Okay, next slide, Ubo. Thank you.
Okay, I'm going to take my notes after this one because there's a couple of things I want to say. Digital ecosystem report. We started the ecosystem report. It's a culmination of actually a couple of years worth of work. A number of different folks have worked on it. I want to give credit to the person in the back here, Robin. Thank you very much for everything that you've done to help coordinate that. At the end of 2019, we released the first report. It was a paper report. It had spotlight on a number of Georgia digital health companies, reports, articles, and you can actually find that on the TAG Digital Health website itself. Realizing that this is a living, breathing document, digital health companies here in Georgia, they're coming and they're going, we wanted to make it a lot more interactive. And so we're actually going to have an interactive version of this particular report with all of the different companies represented here in the late fall timeframe, hopefully, and before the end of 2021. There will be something you can click on, you can interact with, you can search, you can do a bunch of different features. We'll have a lot more information about that as we progress and actually move it into a live system itself. We will be sending out an email later on this year about it, sometime later in August. And as always, if you've got any questions, you can reach out to Robin for additional information. With that, I want to go ahead and shift gears. First, I'd like to thank the event committee. Well, if we can skip to the next slide. The event planning committee themselves, we obviously can't do this without the support of volunteers from the TAG board. So obviously, huge thank you to everyone that's participated in putting this event together, most of which is Anita, who has been doing a lot of the organization around it. So thanks very much to you, and the rest of the event planning committee as well. And we can't do any of this without the support of our sponsors. And what we have set up with TAG Digital Health is we have a number of society sponsors. They help us throughout the entire year, and we have event sponsors as well. So with that, I want to turn it over to Venkat and discuss.
Thanks. So Anthem is really happy to sponsor this event, and we are. For those of you that don't know Anthem, we are one of the nation's largest healthcare providers. Again, we don't want to call ourselves an insurer. We are a healthcare provider, and through our affiliates, we serve about 106 million people across the country, of which 43 million thereabouts is we provide health benefits. So really, if you think about it, that's 1 in 7 Americans, right? So we have a wide reach across the country. And in the markets that we're present, we have a lot of depth. So for example, here in Georgia, we insure, close to 3 million people, right? So we have a large presence in the markets we operate in. Our mission is very simple: simplifying healthcare and improving lives and communities that we operate in. And as a company strategy, we really like to focus on bringing value to the healthcare ecosystem, and that includes stakeholders across the value chain, right? So starting from the members we serve, the 106 million people we serve, to all the healthcare providers, our employers that that purchase insurance on their employees' behalf, our associates themselves. We are 80,000 strong, right, Anita? And then our stockholders, obviously, right? So we serve a lot of stakeholders in the ecosystem, and the care coordination challenge is close to our heart because we deal with these challenges on a day-to-day basis. And I particularly work in the data management space. I run data management for Anthem, and in today's digital world, it's all about data, right? Data is the currency of the digital world. And without having accurate information and timely data about all the care coordination supply chain, it's hard to provide hard to coordinate. So this idea is very close to my heart, and I'm happy everybody's here. So thanks for the time. And
also, as I mentioned before, we've got society sponsors. This is an annual sponsorship. We generally split the annual sponsors, the society sponsors up between a couple at the beginning, a couple at the end. So first we'll have Fahad from Azalea join us.
All right. Thanks, Brian. My name is Fahad Salim. I am Vice President of Client Services at Azalea Health. We are a technology platform that provides EHR or healthcare solutions to doctors and hospitals. In addition to that, we also provide services such as RCM services and pre-cert services. And our mission is very simple, is to help underserved healthcare providers. Robin Hackney actually came up with our mission, so I'll give her a shout out. To help underserved healthcare providers improve patient care and profitability. But I'm here, one of my colleagues is here. If you guys have any questions, feel free to come in and ask us any questions. Thank you all.
And Bill from Deloitte.
Hey, so my name is Bill Love. I'm an audit manager with Deloitte out of our audit and assurance practice, but specifically I focus on our digital health and health tech national leadership team. So with that, we publish 2 documents each year. One is obviously focused on technical accounting concepts, really focused on what are companies in the digital health space, components of traditional technology companies and life sciences healthcare. What kind of accounting concepts are really going to be relevant for them as they need to evolve their business and grow, and kind of define where the industry is going. So all of that is going to be focused on revenue, accounting, software capitalization, and things like that. But if you're not focused on technical accounting concepts, we also have a document more focused on just overall insights into the market trends, which, I'm sure I don't really have to tell this group, the digital health market has just been booming over the last year and a half. And really with that, the health tech innovators and the companies really thinking about where is this going to go forward and over the next 10, 20 years. Really been defining the COVID-19 response, kind of how the market's really shaping up with that. And so we're trying to identify, what are the market themes underlying that, who's driving it, or these companies identifying themselves and focused on as data, as platforms, and this and that. And really, how is that translating into this massive boom that we've seen in digital health funding, really again, over 18 months. So again, if anybody has any questions, happy to talk about it. Thank you.
Excellent. Finally, I'd like to go ahead and introduce Anita. I want to make sure that I get this right, so I'm going to do a little bit of reading. Anita is someone who did not grow up in healthcare, but through a series of professional and personal experiences, she chose to make healthcare a focus of all her professional endeavors. She's passionate about all things healthcare, but mostly about bringing thoughtful simplicity in it and asking the question, why not? Over the last 26 years, she has held leadership and advisory roles in Fortune 100 companies and a brief stint as an entrepreneur. Currently, she is Director of Strategy at Anthem, working on initiatives that design purpose-built products to drive care outcomes and create trusted. With that, I give you
Take the slide up.
Should I be glad? Just say next slide.
No, don't go to the slide, just remove the slide. Let's
Oh,
just have the
take
screen.
the slides down and
Take
go.
the slide down. and foremost, thank you, everybody, and especially with this rain. I think we have some people who probably swam through now, and that's an adventure. So appreciate it. Thank you, Brian. As Brian mentioned, this is one of the first hybrid events that we're having. We really appreciate having you here. Before we get started, let me ask a couple of questions. How many of you have had experiences where either you've had to take care of your family member, your parents, your children, having to go through multiple physician offices, multiple visits, having to get prescriptions, having to get tests done? And how has that experience been over the last few years? With any comments?
Frustrated.
Anything else?
Expensive.
Expensive?
Time consuming.
Not surprising, right?
Right.
And that's one of the topics we're talking about. How many times has it actually worked? And I'll be honest, it's not all bad. My personal experience is that I've had some good ones, right? I've had my PCP helping me coordinate appointments. But any good experiences?
On the dental side, I've had an orthodontist, periodontist, and dentist communicates without me having to be part of every conversation. And I walked into a room and they actually knew what the situation was, and I didn't have to brief them. So I was pretty excited about that.
How many of you are happy that you actually have a neighborhood details clinic? Or a pharmacy that's nearby that's able to do specialty drugs, right? How many of you are happy that there is actually a lab? You don't have to go through a big building, just walk in, go get your test done and walk away. And there are some good experiences happening. How many of you are happy or aware that in 1846, when I think his name is William Morton, he used anesthesia on one of his dental patients, that actually changed medicine. And there were a lot of different care and procedures that got done. We had a lot of new care. There was medical science that created a number of discoveries, right? And we were able to do 1928 antibiotics, right? That changed things for us. So we actually go to the next slide.
You took the slides off. Do you want them back on?
Yes.
Okay, if I'm, can you put the slides back up, please?
If you think about it, right? Modern medicine has created remedies. They work. The number of conditions that we have cures or remedies for has increased manyfold. The fact that we have specialty drugs, the fact that we're able to digitally able to connect with our physicians, the fact that we're able to connect, right? The number of procedures, the number of drugs, everything has increased multifold. The fact that we have specialists, aren't we all happy that I might have a very unique condition and there's a specialist who can actually talk to me about it somewhere in the world, but there is someone, right?
Hey, Anita, I heard a request. If you could speak up, people are having difficulty hearing.
That's what I thought. Sorry about that.
Just
I'll
pick up
try.
on
This is, I call that my manufacturing defect, but I'll try. I'll try, right? The fact that we have remote patient monitoring, the fact that we had virtual care, right, during the pandemic, being able to connect recipients with their patients, the fact that we were able to do things, technology has brought caregivers and care receivers closer, right? At the same time, we talk about reimbursement models, and I will definitely say this is not a philosophical or a political or an adversarial conversation, but different regulation, different payment models has also impacted, I'll try that, has also impacted how we receive care, what care gets covered, what choices we make in our caregivers, right? That has also changed things. Last but not the least, regulation is still catching up, right? So there are a number of things that have been good about the innovation, modern medicine. Care has got distributed, but more conditions are being covered, more treatments are available to people. There is a lot of good happening, right? If you go to the next slide.
Next slide.
The thing is, the one thing that we all will agree on, right? For all of this care to get done, right? All of us agree that we are about the whole person's health. And if we have to talk about care coordination, it's care coordination for the whole person's health. I think a number of you have seen like some numbers at the heart of it. If you think of what impacts health or our outcomes, right? Predominantly, more than half of that is our lifestyle and our genetics. Right? And therefore, now think about all the things that have to get coordinated. There are a number of devices that actually capture what we eat, how much we run, what we do, etc. Right? There are things that are capturing our lifestyle. There's a lot of work that's done on genetics, right? So that is something that becomes an input to care coordination. Next is, I think there has been a lot of work done on what we would call the socioeconomic factors, right? We call them social determinants, we call them health equity, we call them a number of things. But at the heart of it, right, think about job safety, food safety, education, income, all of that matters, and all of that starts impacting our health. That's another layer of information and input that has to get coordinated. Last but not the least, the care itself, right? With all the specialization, with all the drugs, with all the technology, think about what all is getting coordinated, right? And one could say, hey, this is nothing but a whole bunch of SKUs getting added to our care. Amazon handles many SKUs, right? If I go back to the first question, right? How was that experience? And not kind of went through a terrible care coordination or terrible experience. If I flip that question and ask that, how is your experience when you're going on a vacation or a business trip? You have 3 flights, you have hotels, 1 flight got missed. You probably wouldn't feel it as bad as a healthcare episode going bad, right? Because healthcare matters. Point being, while Amazon can handle a whole bunch of SKUs, while Amazon can manage supply chain, while Amazon can do a whole bunch of things, when it comes to healthcare, coordinating all the different inputs that are going through an individual's life, right, is not easy. If one thing goes wrong, it can be a matter of life and death. Right? With that said, today on our panel, we have a number of experts. I'm going to let them introduce themselves, but we will have a good discussion on is there a solution? I don't think any one of us can kid ourselves saying that there is a solution emerging, that there is a perfect model. So actually, we actually at Anthem say that it's actually care for N is equal to 1, right? It's definitely not one size fits all. There's definitely not one model. It is going to get customized with all the factors coming in, with all the technology. It is complicated. Right? With that said, I am going to welcome our panel and thank you all for joining us in this weather. And I have to say, I've been working with this group for the last several weeks. It's been fun. It's been great discussion, and we learned a lot. And I think, frankly, when we were kind of going through our discussions, like, hey, this topic can take almost a day, a conference by itself. I'm going to try and cover it in the next 1 hour. I'm sure there'll be a lot of questions. I'm sure there'll be many questions that we'll have, that we'll say that, hey, we don't know the answers to. Yeah, perfect. Right? But look at the complexity that our ecosystem has to handle. And that's why it's important. And as Venkat mentioned, like data is important. Technology will help. But at the same time, there are many other things that we have to think about. With that, Vincent, why don't you guys come over and introduce yourselves, talk a little bit about what you're passionate about when it comes to care coordination, and then we'll go to questions. Start with Vincent.
Hopefully you can hear me.
If you guys could speak in the microphone closely.
Actually, you speak over, but yeah. Sound guy at church, I can do this. So basically my background is I spent over 20 years in the managed care arena. And I started within the pharmacy area, and that kind of ballooned over to both the pharmacy and the medical area. And that my boss felt that medication is a medication, no matter where it's being used, be it the pharmacy, be it the medical, I get the entire picture. So basically, I am the drug guy. And during my time with managed care, I started trying to get into the core care coordination arena, the realm, so to speak, by putting in the first plan-sponsored oncology clinical pathways program. And as Anita reminded me earlier today, I am kind of coined as the grandfather of clinical pathways in oncology. So I gotta get gray here, I guess. And what that means is basically it's the first time that a health plan reached out, collaborated with the network oncologist to put together a treatment pathway program that basically is trying to go and help define what the most cost-effective treatment regimens are for any particular patient, based upon the efficacy, tolerability, and cost at the end of the day. That was in 2008. Clinical pathways have gone a lot farther since then, here in 2021. And a lot of the stuff that actually Shanta's going to be talking about is now being taken into account as clinical pathways are being put together. From a pharmacy aspect, I also, with the Medicare Part D program, integrated pharmacy, community pharmacists into counseling patients as part of the medication therapy management program. Most of the services that were provided by Part D programs at the time were really from call centers. Mine was basically taking it out to the community to get that pharmacist involved. So basically, since 2013, I decided I got tired of the corporate world, came out as an independent consultant, and I work with pharmaceutical manufacturers, genomic profiling companies, device companies, and again, going back to the care coordination, working with digital apps, because especially during COVID, digital apps is what's bringing the patient closer to the physician when they can't, or when they really don't want to travel. So basically, that's what I do, when I'm coming from, and where I'm coming from, and you'll hear more from me later.
Thank you. Thanks, Winston. Next, we go to Dr. Joshua now.
Everyone, can you hear me? Great. It's a little weird to see my own face on the screen, but I will try. Great to be with everyone here virtually. I apologize I couldn't be there in person. I am located in Seattle, and actually, is a great segue to the first thing that I do. I'm a practicing physician, and I'm seeing patients in Seattle, so can join you there physically. Outside of that, I wear a few hats. The first is I'm the enterprise medical director for payment strategy for our health system here, our hospitals and clinic networks. I'm also fortunate to work in a number of state and national kind of policy roles, thinking really hard about how public decision makers cascade programs that then payers, providers, people in different sectors will then pick up and use to try to drive things and outcomes like care coordination. I'll be brief in my comments. I'd love to get into the questions and discussion, but I think the perspective that I bring is one of a clinician and a provider organization, but passed through kind of a filter of policy translated into actual practice in the healthcare sector. So thinking back to what Anita showed on a few slides ago, maybe predominantly that outer ring. It's great to be with everybody.
Thank you. Glad this worked out. We were running into technical issues earlier, but it worked out. Thank you. Shanta?
So good afternoon, good evening, good morning, wherever you may be. So I'm Shanta Chambers, and I have the pleasure of, I work for, of course, the Patient Advocate Foundation. And in my work, what I have the pleasure of doing is actually addressing the intersection between health and the social determinants of health. Because oftentimes we make the assumption that people live in a bubble, right? So think about all of us in our healthcare experience. When we're within the four walls of that healthcare system, we can be as compliant as you need us to be. Because at that moment, we're separated from all of these other things that are going on in our lives. But patients, they're still processing everything. So as they're in the four walls of our healthcare system, yes, we're being cared for, they're being cared for, but at the same time, they're processing, oh, I have loss of income because now I've had to take so many days off work to be here. Oh, who's going to be caring for my children while I'm in this facility? Oh, what is it going to be like when I have to go back? Oh, I forgot I have 4 buses and 2 trains that I have to take to get back home. So for me, in the work that I do, we talk about care coordination. We have to think about it, as Nina pointed out on one of her slides, it's not just about the medical aspects of care coordination. It's not about just the delivery of care, but how do we create space so that the care coordination that we're talking about, that we really dismantle this historical approach where we're talking about care coordination for patients, but we're talking about it in the absence of creating space for patients to really inform what that care coordination looks like. So needless to say, I'm excited to be here with all of you today. I look forward to this conversation.
Thank you. Last but not least, Andy.
Hi, everyone. My name is Andrew Brecker. I'm a client success leader with Signify Health. I've spent my career in healthcare technology, working in a number of different platforms, supporting the delivery of technology and services in the acute, post-acute, and now focused and ambulatory settings, but now I'm mostly focused in the transition from acute to post-acute space. And in my roles and my time in working in healthcare technology, recognize that technology is a tool that it needs to be used to deliver a solution, but there needs to be services and people that are effective at using that tool. And so when you think about the kind of the concept and the idea of care coordination, it's not something that necessarily technology can solve by itself, but it's something that technology is incredibly important to facilitate. And so in our discussion today, as I've always been talking about, I'll be representing the kind of point of view of technology and the importance that it plays in driving coordinated care.
Thank you.
So I'll direct the first question to you, Andy. Right? From a technology perspective, what do you think is working?
So from a technology perspective, I think there are constant improvements in the way that technology is being delivered and the way that technology is communicating with each other. I think one of the shortcomings of technology, I guess I'll start there to get where we are now. One of the shortcomings of technology is there are a lot of companies out there that are building their own platforms, their own solutions, their own systems, and there's not a lot of great connectivity between them. But there are standardized ways to communicate between platforms. There's a lot of work to be done to get these platforms to exchange information. I think critical in any care coordination is the exchange of information, whether it's financial, clinical, just basic patient data. I think it's critical that gets exchanged. And so issues that arise, and I've seen this in working in hospitals, when integration goes down, you lose that connectivity, you lose that ability to deliver the right information at the right time to the right person. But I think one of the things that we're seeing change in healthcare is the willingness, and some of this is driven by policy, but the willingness for companies to actually start to work together and create these ecosystems where you can exchange information across platforms more effectively. I think the bane of, at least in my experience, every provider's experience when delivering care is that additional click, right? And so finding ways to prevent that additional work that they have to do to actually go execute delivery of care and the delivery of care and information to other people that will be critical in the outcome, driving positive outcome for the patient.
So I think next I'll ask the same question to Dr. Josh, for what are some of the challenges that you experienced and then what is working from your perspective as a physician?
Yeah, and you mean with regards to technology?
No, from a clinical perspective, like from a care coordination.
Yeah, I think Andy and others have hinted at this, but I think one of the biggest challenges is, to sum it up in a word, accountability. And that's a word that's thrown around a lot. I don't mean to do that more, but I do think the idea of coordination is a good one, hard to argue it. But I think when it comes down to who's responsible for what, drive which pieces, I think it becomes a lot harder. And that's much of thornier of an issue. I think also it's how we think about how to join the pieces as well. If you think about care as episodic, if you think about comprehensive, even if you take a quote comprehensive global population view, the nuts and the bolts of how do you move between care settings, how do you leave the healthcare setting, how do you engage patients in a really active way, all of those things, where the devil lives proverbially, it's there, that stuff works out. And I think how we think about care coordination then creates the challenge in some ways. For instance, if we think about it from the clinic to the hospital, but that doesn't encompass the hospital to post-acute, right? Then we've created another dimension where we have to then coordinate that, right? It could or could not be that way, but that's in part how we're designing it. So I guess this is a little introspective for me, coming from a provider organization and saying, there's no shortage of challenges here, but I think one thing that I grapple with is how we approach the issue almost affects how we see the challenges in some ways.
What's your take on the challenges and some of the things that may be working?
From a payer perspective?
From a payer perspective.
Okay. Now that I'm not a payer, I can be very frank as to what my opinion is. If you look at the traditional payer and they have their traditional utilization management programs, prior authorization pre-certs, case management. A lot of that is very episodic, but a lot of that is really to look at medical necessity. It's not, it may, they may say it falls on, case management may fall under the coordination of care tab, but it's really a matter of trying to go and determine what's medically necessary to provide coverage for, because payers, quite honestly, don't want to pay for services that aren't necessary, not appropriate, or excessive. I think Venkat actually said it best. The best thing that a payer can do in terms of care coordination is to provide the data. The data is going to tell, or basically describe or indicate what services have been provided. And the one thing that's always necessary, especially when you're a physician organization trying to go and engage into some of these value-based programs, you got to know how much you're paying for these services. Because in terms of being able to coordinate care, you got to know who your providers are, or who your referrals are going to, what the cost of those referrals are, and if there are different networks out there, or preferences even by the payer, whoever's going to coordinate for that care, who's going to be held accountable for that care, needs to know how much it costs. So from a payer perspective, I don't think payers do a real good job, quite honestly, of coordinating care. I think they finally realize that, and because they finally have realized that, they've gone one of two directions. First direction is that they're going and forming joint ventures with integrated health system, multi-specialty practices, to where it's one-sided risk. And basically their proposition to the practice is going to be, if you can cut your costs and you can maintain your performance measures, we'll go and give you an incentive bonus. They're basically trying to go and buy care, coordinated care through the practice. The other bucket is going to be where you have the payers who are trying to, or basically acquiring the physician practices themselves. So basically the practice of the provider of the care and the payer of the care becomes one. It started with the Kaiser model, started with the Geisinger model, the integrated health system. Now you see the major insurance carriers. I think Anthem's one of them. Definitely United, definitely CVS Aetna, where they are acquiring and providing care. In fact, CVS Aetna is even providing the minute clinics, so they're providing even acute care. So from that aspect, they are able to go and have, as Andy put, that transition or the sharing of the data that's at an easier connection, because those practices are going to be tied together with the plan and the claims data.
I'll actually add one thing, but you probably know more about this. So Anthem actually is integrating EMR EHR data into its ecosystem. So we are actually working directly with Epic, I believe, right, to integrate with the EMR EHR system. So that's another approach that a health plan is also taking to integrate the data to create the care coordination. I would say routines, or try to figure out how best. I personally like to use the word pathways, and I'm a little bit out of pathways, but I think that there's a lot to be done, and I think there are other models that was kind of working through. Shanta, from your perspective, I do want to focus on what are some of the things that are working, right? I think there are lots of challenges, but I do want kind of, what are some of the things that are working, and therefore those models can be replicated?
So I get tasked with having to put a silver lining on things. Well, before the lining, I think is critically important for us to, I've heard a lot, but what I still have not heard is a focus on patients and what all of this means for patients, how we create space. Because what I hear is a conversation around transaction versus relationship. And so we're talking about things as if they are transactional, whereas for patients, they're looking at it and they're thinking about the relationship. And so when I start to think about the silver lining here, I think as we think about our path forward with everything that's been going on with the exposure of all of many factors in terms of racism and structural biases and things of that nature as a result of the pandemic that's been unveiled, I think for the very first time, what we're doing is we realize that we need to deliver healthcare differently. We're realizing that we have a great opportunity before us to actually deliver healthcare in a way that meets people at their point of need, where they are, in a mode, in a fashion by which they are most comfortable, in a way that is most accessible for them, in a way that it is not the convenient Monday through Friday from 9 to 5. Because had it not been for a pandemic, would we really be having this conversation around the urgency of how we really think about care coordination? If it had not been for the pandemic, will we really be able to really maximize the use of technology infrastructure in the way that we deliver care? Think about it. Telehealth didn't just surface in 2020. It's been around. But why was it now? The innovation, why was it now that we decided we wanted to be provocative enough and say, hey, let's really look at these platforms and see how we can deliver care differently? So yes, there are some things that are working well. I just caution us to be very mindful that we have to ask ourselves, as we emerge in this technology space, who will we leave behind? We have to make sure that our systems can support the millennials and it can support our seniors, because they're still very active. So we have to be mindful that one size won't fit all. It may not fit most, but what I do know is we have the innovation, we have the technology, we have the expertise, and we have the courage to be provocative in our path forward.
Love that. So one question that we all kind of grappled with when we were planning, preparing for this discussion was, should care coordination be centralized or decentralized? And I'm going to say, who from the panel wants to tackle that? And if there is a point of view on care coordination, decentralized or decentralized?
I don't see if you're looking at me. I'll take the first crack at this.
We're booking
Andrew,
and we're booking
So I think I've been grappling with this a lot. I think there's a level of complexity at which care coordination needs to move from being decentralized to centralized. There are certain conditions, and I'm not a physician, so I'll leave it to experts to identify what that threshold is. But there are certain things that a patient could manage themselves, and not all patients can, right, depending on the need of the patient. But at the center of care coordination is an individual. And so the question is, can that individual manage the care that they need themselves? Is the complexity of the issue minor enough? I'll use myself as an example. A number of college injuries have added up. I have significant trauma in my feet and now have gout. So I had to go from an orthopedic specialist to a rheumatologist. That was a simple thing for me to manage, going from one to the other. But there's significantly more complex health issues that require a lot of support and assistance in navigation. And so when it comes to the centralized delivery of care coordination, it's how complex is the issue? Can a person manage it themselves? And then the other side of it is, what other factors are preventing them from getting care, right? There's a lot of technology companies out there. One of the companies that I'm familiar with, I think was acquired recently, Circulation, that was simply focused on getting patients to appointments, because patients who couldn't get to appointments were not compliant, were getting worse health outcomes. And they weren't focused on the delivery of care. They were effectively focused on the delivery of a taxi. And that was a huge driver of positive outcomes. Right? And that was, again, a technology-based solution, leveraging integration with EHRs to identify patients who couldn't get there. One of the things at Signify Health that we've been really focused on are the social determinants of health that prevent patients from getting the positive outcomes. And so what are the factors that go into a patient's experience that prevent them from receiving the care or the medication or the treatment that they need to get to a positive outcome, and how do we allow that and facilitate that in the home? So Shanta, one of the things you were saying is we have to meet people where they are. And one of the things that we focus on is healthier days at home. And so one of the services that we're rolling out in the initial stage is a transition to home service, where we're actually calling patients when they're in a 90-day episode. But when they transition out of an acute facility or out of a post-acute facility, figuring out how do we get them the care they need. And so in that instance, we're working to almost centralize that coordination and be their touch point to say, are you able to get to this appointment? Are you able to afford your medication? Are you able to follow up on it? I think the patients that we serve are Medicare patients, so it's older population. who may not be as, I don't want to paint everyone in a single bucket, but may not be as tech savvy and may appreciate the outreach to support that level of coordination. But notwithstanding putting myself in a weird position to reveal my medical history, I think level of care coordination, again, it depends on the patient and the complexity of the issue being addressed.
I'll be a definite advocate of care coordination being as a centralized effort. Who actually oversees and is held accountable for that care coordination, I think that's up to the debate. I'm usually one who thinks that the PCP should be the person who's basically the driver. And if the specialist is needed, it should still be the PCP that does that referral, that stays on top of whatever whatever activities or services that are being provided for that patient. Obviously, the systems need to be put together so that we do have coordination of care in terms of the data coming across, in terms of the services, the data, as well as even the results. We heard earlier the dental procedure where 3 specialists talk to each other. But if you look at something as simple as emergency room visits, what is the level of coordination between an emergency room visit that happens, let's say tonight, and a PCP calling the patient saying, I heard you were in the emergency room, please come in tomorrow so we can see what's going on with you. You go in and that physician has no idea what services have been provided. He orders an entirely new set of labs, which has already been drawn in the emergency room, so you have excessive use. And that's a simple example. A more complex example is you have a PCP with a patient who comes in and says, I have this pain down here in my tummy. So he does some prodding around, does some x-rays and see a mass. That person gets referred to an oncologist. The oncologist is looking, doing the biopsies, ordering a set of labs, and says, I think you have a stage 2 tumor here. We probably should resect it. Sends it to a surgeon, a surgical oncologist, who runs the same set of labs, another set of x-rays, and then takes him to surgery. And then after that, usually the person's going to go to get radiation. The radiation person, the oncologist, is going to pull a set of labs to make sure their blood counts are still good. Basically have to go and do x-rays to see where the scars are so that you go and hit the right place with the radiation. So there you've got 4 sets of labs, and you probably could have done 1 or 2. That's where the coordination comes in. And as Dr. Lau said earlier, it comes down to the accountability of who's going to coordinate it. And then, especially when you're looking at, as Andrew and Shanta said, when you got that patient who's out there, and let's say that patient's 70 years old, who I just described with a GI cancer, that person probably doesn't have the ability to coordinate all their cares and trying to make sure which doctor is going to whom, which labs are going. They're just doing what the doctors have told them. And there's no thought of basically, as Shanta was saying, with the social determinants, how's that patient going to get to the doctor? How's that patient even going to cope from a mental standpoint that they can comprehend actually what's even going on with them?
Complicated. That's all I can say. Dr. Jack, I'd love to hear your perspective on should care coordination be centralized or decentralized?
Yeah, my one-word answer is yes. I think, it's, I'll draft off the complexity that Winston really described well and just say, I think the word that keeps drifting up, like jokes aside, is really this question of distinction. I think if there is centralization or there's not, there has to be recognition that it's not a one size fits all. I don't think we would be sitting around this room or dialing in if that were the case. I think we would speak only in the singular if that was the case. I think we know that in some deep level and on the surface, but I think the tension I see is that I think as being hinted at is healthcare is highly complex. There are information asymmetries. It's hard to understand sometimes. And in that way, I think healthcare providers play a really important role in educating patients and making decisions kind of with them. We draw that circle with lifestyle. It's so simple, right? There are kind of a manifold decisions that go into that. On the other hand, I very much believe that patients own their data. They have agency in their own decisions. And being tied to certain systems that they're not engaged in is really counterproductive. And so those are not at odds, but they create a spectrum, right? Wherein I think we have to just recognize that diversity. And so it's hard to say, kind of pull a lever, care coordination should be central or totally decentral. I think we could spend hours talking about the horror stories if either were true. And so I wonder if maybe a way forward is to think about certain functions that have to be centralized. I think accountability, I think certain incentives have to be there. And then what are the things we can kind of shift out to the periphery that really, frankly, without that, patient engagement, without the competition, without the options and the choice, won't work. That's how I've come to see it. So, I mean, I do think, yes, both are needed, but the functions are probably what need to be central or not.
That makes sense.
I actually, first of all, Dr. Bob, my new best friend, because he actually talked about co-decision making or shared decision making with patients and actually engaging with patients in the process. And I think there are some elements that could be decentralized. For example, there could be factors around social needs that actually could be decentralized. They may not necessarily need to be a part of the care coordination centralized process. However, I think even if we think about decentralizing some of the social needs elements, there will be partners and entities that will need to be connected to that information flow. So I think, again, it's going to force us to think differently in terms of how we deliver care. Ask ourselves who is not at the table by which we need to engage that may be even critical to the centralization or decentralization of care coordination. And so I do agree, there are some elements that should be centralized. I think more importantly, the centralization is more critical for patient adherence. So if patients don't have to go 6 different places, because there is a cost to decentralization, and the patients are actually the entities that are bearing these costs, whether they're transportation costs or parking costs or other logistical costs. We have to understand the social and financial context of what we're talking about in terms of decentralizing or centralizing in the eyes of the patient. I'm going to always bring this back to the patient, because at the end of the day, when we're talking about care coordination, that is the entity that should be able to make this.
Love that. All right, we're going to take a couple minutes break and invite, is somebody from Integra Connect here? No, so we just want to thank Integra Connect as a sponsor. They couldn't be here, but they are our society sponsors. Juno, would you like to say a couple of words? Sure.
Thank you. Good afternoon. My name is Christopher Cunny. I serve as Chief of Strategy and Business Development.
Come back over.
Hi. Christopher Cunny. I serve as Chief of Strategy and Business Development for DSS Incorporated, and Juno Health is a subsidiary company of DSS. Very proud and excited to be working with a company that is launching a revolutionary cloud-based electronic health record system for the inpatient and ambulatory market. As you know, the journey of the EHR started out as a data repository system, financial collection system, now really a clinical management system. The monolithic EHRs out there are falling short in meeting the needs of our clinicians. And so DSS is 30-year-old healthcare IT company that's cut its roots in the VA and with state agencies has decided to take on some of the Goliaths out there and start to bring to bear a revolutionary EHR. Working side by side with companies like Azalea Health, who's out there doing the same thing as well. We've got to bring other options to the market besides the ones that are continuing to dominate the market as well too. And so we, like many companies like the Azaleas and DSS, are hiring clinicians, lab techs, pharmacists, doctors to reimagine what an EHR should be, which is an advisor, a tool, a resource for clinicians to provide better care, but also a tool that allows us to manage business operations much more efficiently. So we are launching our product at HIMSS this year. So if you are coming to HIMSS, please stop by our booth. It's called Juno Health. We'd love to show you what we're doing. Thanks for allowing us to support this.
Thank you. And Shweta, do we have Shweta Online. She's on, okay. That's Kennesaw University, that's our society sponsor.
Anita, while you're waiting for her, I might invite people to go pick up a meal if they haven't picked one up yet.
Sure.
They could eat while we're listening.
Absolutely, folks who haven't eaten, please go ahead, grab a meal, grab a snack.
I'll just grab the water.
As for swallow.
We're not judging. We can-
Can you,
All right. Anita, do you want me to wait?
no, go ahead, Shweta.
Okay, I'm just waiting for this. Okay. Thanks, Anita. My name is Shweta Sneha. I am the Executive Director and Professor of Healthcare Management and Informatics at Kennesaw State University. We are in the business of education, outreach, and innovation, and very happy to be affiliated with TAG and all the amazing work that the society does for the community. Our students have engaged with all of TAG events multiple times in the past and continue to do so. We also partner with the industry very heavily in ensuring that we work with them on research and educational opportunities. We have worked in the past with Azalea. Chris is on our board, and we worked with Anthem and others as well. Would love to hear from you on ways we can collaborate and move the needle on workforce in healthcare informatics and technology. Thank you.
All right, now we're going to go into our next round of questions, which I'm hoping are more challenging and more difficult. Let's start panelists. That's the idea. All right. So the first question, the next question is for Andy. What are some of the innovative technologies that you think can help, right, be used? Maybe what are some of the new things that you believe can solve some of the problems that you're talking about with care coordination?
So I'm going to start by saying I'm not an expert on blockchain, but what I will say is one of the biggest challenges in healthcare is the exchange of information between platforms. And one of the things I've also seen in healthcare is that healthcare is like operating like the banking industry for 20 years ago. Right? The adoption of technology, the consolidation of companies, and we're seeing the adoption of blockchain technologies and the exchange, the secure exchange of information in support of banking. And there's the notion of as using blockchain, and again, I'm not an expert here, but using blockchain as a technology as a way to exchange healthcare information that's specific to a patient. Dr. Lau said, firmly believes that data belongs to the patient, right? Their health data belongs to the patient. And the notion of if you're at all familiar with any cryptocurrency, the notion of a wallet where you store all of your information, all of the currencies that you hold, that you can have a wallet that was for your healthcare data. And so you as the patient then have that access to have all of your own information stored in a single location that then you can choose who is shared with. So that does push a little bit on the centralization, decentralization question around the patient owning the data, but it's also about providing access to that data. So that's one of the areas I think from a technology perspective where emerging technologies could be leveraged. And I know I think the event in November is going to be partnered with is going to kind of touch on that further, I think. But that's certainly one of the technologies, one of the new technologies that I think healthcare may be able to leverage to better facilitate the exchange of information, which facilitates the coordination of care. I think the other technology that we're seeing more and more of, and I think about what's going on in the field, right? So one of the things that we focus on at Signify is that patient's 90-day, so that post-discharge, what's happening with that patient. And we focus on the conversation with the patient, but our partners, the health systems and the hospitals that we work with, are doing a lot of work with remote patient monitoring. Right? So devices in the field that I don't think that's a new technology. The technology wearables are getting better and better. Is having data on that patient that triggers outreach. Right, something seems out of place, a reading comes back out of place. So I think as wearable technology gets better, you're going to see more coordination of care because of an automated outreach to a caregiver. I think at the end of the day, when it comes to technology, I think at the beginning, technology is a tool and it has to be in the right hands of the right person to make the right decision that's going to drive a positive outcome. Technology by itself isn't the solution, but it enables a successful implementation.
Dr. Joshua and Winston, this is going to be a combined question, and Winston, you're going to wear your payer hat. So to be a caregiver or a clinician, right, Dr. Joshua and Winston as a payer, what do you think the care coordination or the operating model of the future should be that enables or makes care coordination better?
All right. So the future, how far out you talking?
You get like 5 years, 10 years?
5 years? Okay.
5 years.
Okay, my thought is if I look 5 years out, what am I seeing? I'm seeing probably more alternative financial models that are out there, more joint ventures. And I think you're going to hear Josh say that these joint ventures, if he does his job well, is going to be two-sided risk. It's not going to just be the payer saying, we need to go and lower your costs, and we lower your costs, we'll give you an incentive. I think there's going to be risk on both sides. I think the payers, to a certain degree, need to go and take some accountability because the data that they're giving needs to be much more sophisticated, it needs to be cleaner. And what the data is saying is that they're pulling data from the electronic medical record, and that's being passed through. Payers got to have some accountability that that data is correct. I think we're also going to see more, from a payer perspective, I think we're going to see more consolidation of the industry, where we're not going to have these small little regional local health plans out there that want to become part of the bigger health plan. And we're not going to, and we're already seeing the degradation of the community practices because they're being gobbled up by the large integrated health systems. So we're going to see a bigger joining between the payers and the health systems so that there is better coordination of care. In terms of who gets this coordination of care, I think the ideal is everybody gets coordination of care to some degree. The level of care is going to depend upon the patient. If you have a younger patient who is a new diabetic and they don't have any of the comorbidities and all they're really trying to go to do is go and learn how to go and control their diet and monitor their A1Cs and monitor their blood sugars, usually a younger person is going to have that ability. But then there are certain populations, even the younger population, who may not be as well educated, can't understand their condition, and they are definitely going to need a higher, basically a higher level of care coordination. And then you have the older population who's going to have many comorbidities, many conditions. Their conditions are going to be very complex, and obviously they're going to be in need of more care coordination as well, and they're probably actually going to be higher costs. So I think the payer will usually tell you they're going to focus in on the high-risk patient, the complex patients, the patients that are costing you more money, are basically taking the bulk of it, the bulk of the money. I think the rule usually is that 1 to 2% of your patients are going to be basically 20 to 30% of your costs, if not more. So, that's who they're going to focus in on. But I think in order to truly make care coordination a real thing, especially if we have the technologies in place, especially if we have the realization of the social determinants that are out there, I think basically everybody needs care coordination. It's just a matter of what level.
Dr. Joshua, what's your perspective on what will be the model of the future that will deliver better and successful care coordination?
Dust off my crystal ball. I'll go the 10-year. When someone went 5, I'll go 10 and say, I agree with a lot of what's been said. I think I go back to the initial thing that I said around accountability. I think for care coordination to really take hold, there has to be a sense of who's lead, who's primary, who's secondary, et cetera. You know, like whether we're talking about social determinants or coordination needs, these are not like laundry lists of things to know, right? As if I know people need these 5 things, like that's it. Or I know that this person saw 5 clinicians, that's it. There's much more important how those interact. And, you know, it was brought up earlier, you know, this idea of engaging people with their primary care doctors. There are patients who view their subspecialists as their primary care clinicians, and that's okay, but that's a level of complexity. There's some people who say, I really don't want to engage in primary care, and like that's important for us to understand, right, as providers. So I think that idea of accountability, whether it's through payment models or delivery models, I think needs to be really robust. We've heard it from multiple people here. I agree. You know, technology is a tool. So the question is, what are the business and delivery models that kind of wrap those together? I think that's something to figure out in the future, you know, hopefully before we're like zooming around on like, you know, hoverboards and stuff. I think that the other thing that Winston said, and I'll take an alternate view on it, which is like, I think some people, their care coordination needs to be more holistic, and some people, they don't need coordination the way we're thinking about it. And maybe that's you know, I don't know if the others would agree with me, but I think the point is some people view their healthcare as very transactional, and I acknowledge that. You know, when I see people in the hospital, nobody wants to see me. It's a very unique experience, by the way, to see people and they're like not thrilled to see you because they'd rather not be there, right? And sometimes that can be transactional and it's okay. In the primary care setting, maybe not. So I think maybe Winston means this, but I would say care coordination, as we've been thinking about it holistically, may just not be in the value set of some patients, and that's okay. And I love the future 10 years from now to kind of reflect that, whether that be data or models or incentives.
And that actually is a good lead to the question to you, Shanta. Not all. Being a patient advocate, do you think patients should be in charge of their healthcare, or do you think an alternative model, and how does that complicate? That's a toughest one, right?
Oh my goodness, this will be lightweight this evening. So I think words matter, right? So I've been asked that question around if patients should be in control or power, what have you. But I think when we use words like charge, that gives the assumption that someone has to win and someone has to lose. And it's not about winning or losing, but it is how do we co-create together the best healthcare experience for individuals. And that's inclusive of how we bring technology as a part of it. How do we really think about the provider and the patient relationship? And I think what's also important is to understand that everyone interacts and interfaces with the healthcare systems differently. For some individuals, it's very episodic, right? And we talk about, I'm only going when it's an emergency, but there's some other social and financial dynamics for why people engage in the healthcare system very episodically. That's another talk. I think some people engage with the healthcare system in a very routine way. And I think we have to understand this conversation around care coordination is a critical one, because some people don't even know what it looks like because they've never experienced it. And it's just like, you know, a good dessert, good old warm apple pie with some ice cream, right? You don't know how good it is and how much it may really satisfy your sweet tooth until someone exposes you to it. And then you're actually afforded an opportunity to experience it. So I think we offer healthcare. We think we made healthcare available, but we haven't fully made healthcare accessible. So when we start talking about whether or not patients should be in charge of their healthcare, it's not about them being in charge. It's about how do we create space for patients to be engaged in their healthcare. And that is a bi-directional relationship that brings to bear all of these other factors that help support the healthiest and most productive healthcare experience for the patient and all of the other levers that are part of it, including the caregiver. So no, it's not about charge. Patients don't want to be in charge. They want to be informed. They want to be engaged. They want to be empowered. They want to be at the center of their own healthcare.
Makes sense. With that, questions for the panel are over. Other questions from the group here, or Jessica, do we have any questions from the virtual participants? If there are any questions in the room, let's get started.
Or in the chat.
We'll see. Folks are online, can send the questions to the chat. That was actually an intense discussion, but go ahead, Brian.
The question is more on technology. What role do you all see, or Andrew, do you see AI playing in care coordination?
So when I think about,
Can you repeat the question for everybody?
of course, so the question is, what do I see the role of AI in care coordination? So when I think about technology needs to be successful, supported by services. Services generally have a human function, someone evaluating, understanding the information that's being processed. I think as we think about the future of AI, being able to take on some of that processing work and reduce the burden of an individual to get to an outcome or a conclusion, that integrating AI almost as a service with a technology platform can provide better information to an individual who has to make a care decision, or a patient who has to understand the information that's being presented to them. I think AI, if we're talking about the 5 to 10 year plan of healthcare, I think AI becomes a significant player in that space. And I think the question is, do we have trust in the information that AI will be providing us?
Oh, can
I think it's also important as we think about AI to make sure that we minimize as much as possible, the opportunity for bias, because we can design a system that is intended to do one thing, but as a result of that, we've seen this play out. So when we start thinking about race and ethnicity and all these other factors, right? We've seen examples of where, if we want to use AI, contingent upon the complexion of someone, it may give some very different information and things of that nature. So as we think about the path forward, we have to, again, ask ourselves, how do we make sure that in the development of our technology, in the execution of our technology, that we don't have this unintended consequence of broadening some of the disparities that we know already exist?
Go ahead, Ron. Yeah, so, can you guys hear me? Great. So, building on the trust question, the trust point that you just mentioned, I think this is going to be for Josh, but open to anybody. We talked a little bit about interoperability and accountability as being hurdles to care coordination. But one of the things that I've encountered in my career, as I've talked to physicians and other clinicians, is trust is an issue, and specifically trust in the data that has been provided by other physicians or clinicians and is stored in the electronic health records. And are they willing to trust that data versus pulling a lab, doing another test, asking the questions of the patient? And so that repeating tests and all that duplication that we worry about gunking up the system, some of that in my exposure has been tied to lack of trust. So I'm curious, A, is that something you've seen as well? And B, do you have any thoughts on how we can build that trust so that we can eliminate some of that duplication?
Sure, I'll make a first pass and love other people to weigh in as well. I mean, I think that's I think you're putting your finger on something really important. I think we've made gains. I'm hopeful that we'll make more gains with things like health information exchanges, regional information kind of exchanges, where it's not inspiring work, but actually plugging in systems where we can actually see each other's data is really important. I reflect on when I first began seeing patients, and I would guess or have to go through stacks of paper. And now things in my EHR allow me, like day to day, I'll do this week, will allow me to look into other charts and avoid ordering tests. So I have felt and seen the difference there. Are we there? No. Could we do better? Absolutely. But I think there is a trend that way. I think one of the things I think of in that question relates back to the previous one about AI, and that if you make the distinction between data and information and insight, I think there are certain things that allow us to move along certain ways. So I see, for instance, AI being great for taking data and turning it into information. But going from information to insight with all the human complexity needs what's the complement to natural intelligence, but it needs that human piece to take it there. And I think the right tool's got to be for the right job. And I think the same thing you're highlighting here as well is that if I can peer into data, I need to contextualize that, right? It has to go beyond the data and information. And how do we take that into insight? That's a fundamentally human thing. And so I do think we can plug in systems. I can see data, I can see information. How we turn it to insight, I think, is the human element of this.
Yeah, and that's the point, and I simply consider that there's a judgment that needs to be resilient, right? So you have to do certain things or not, right?
Anita, I'm sorry, she had a good question. She was popping up there.
Yeah, so actually 2 questions came through. I'm just gonna go to the first one first. I have my mouse working. With a desire for greater connectedness and accountability, how do we see the legislative environment engaging in these trends to make advances possible? By Steve Preck.
So I spend a lot of time hearing about decisions and conversations that my leadership is having with CMS and CNMI around new policy, new ways to drive from the traditional fee-for-service model to a coordinated care or alternative payment model. That's primarily what Signify works in the support of the BPCIA program. And fundamentally within the BPCIA program is that transition kind of light from a fee-for-service model to a value-based model where price is set for a 90-day episode. We're working to keep the patient spend under the target price while increasing the quality of the care that they're receiving, preventing readmission and negative outcome for that patient. So legislation, I think, is critical in driving more care coordination through shifting payment models and extending those types of value-based payment models to other care settings, to the delivery of care, the delivery of services. And what's interesting to me is you see usually CMS or Medicare, Medicaid take that risk first, and then payers and employers following suit. And so what we're seeing now in the industry is with what I'd say is the success of the BPCI and BPCIA programs over the last 6 years or so, we're starting to see payers wanting to come to us and launch episodic programs to manage the cost of care for a specific subset right now of acute procedures, diagnoses. But the notion is that would extend. And so you go from, I think we were promised 2017 would be 75% value-based. I don't think we're quite there yet. But I think the other part of that transition and so dependent, I think, in some part on legislation to drive the shift in reimbursement, which will drive the shift in how we deliver care. But what needs to be there to support that is data. You can't make informed decisions about patients, about the risk score of a patient without having good insight into that patient's health and into what their level of care need is in a particular time or setting.
I have a follow-up to that. What's the real incentive for clinicians to move to a value-based care model? I mean, honestly, I make money whenever you come in when you're sick. What's the real value for me now to move to a model to keep you well? Can you repeat the question for the audience?
So I think the question, if I'm hearing you, is, and I'm assuming this was a practice standpoint.
Even on the acute care side, even more so. Quite honestly.
So the question is, what is the value of value-based model? I think from a global standpoint, the value is more efficient care, more accountable care, more coordinated care, because all that's going to lead to better quality, better outcomes, and lower costs. Because I think to Robin's question of, is it a matter of trust? I would say it's yes and no. I think if you're a highfalutin medical center that is not local, let's say someone here goes up to Mayo, up in Minnesota, they're not going to believe what's going on down here because there is no trust. But I think if you have providers in this area who are local and they know each other. And then it comes down to what Josh was saying, is it data or is it interpretation? They may not trust the interpretation, but a lab value is a lab value. And I believe that, yes, the provider is going to trust that lab value, but the reason why they still run the lab test is because they have protocols in place. If you're diabetic, you have to run an A1C at least every 6 months. And it doesn't matter whether the A1C was drawn by another physician. You're seeing me as a physician now. I need to know what your A1C is, and because we're not coordinated, I need to run it. So I guess at the end, going back to your question, in a value-based environment where you have enough multi-specialists, multi-providers in the entire system under that umbrella, you cut a lot of that waste out. The care becomes more efficient. Hopefully the patient is more engaged because there's coordination with that patient. They don't have to control it, but they've got to be engaged. They got to be knowledgeable of where they are as a patient, let's say as a diabetic patient. Where's my A1C? The patient should be able to tell you, unless they're 90 years old like my dad. But basically getting that patient to engage and having them be a participant in providing and being held, I don't want to say accountable, but basically engaged in basically monitoring their own healthcare, that leads to a better outcome, better patient satisfaction, and in the end, lower cost.
But isn't that more of an incentive for the?
Right,
for the
I think where you're going
Right.
is the volume,
That's
right? It's
right.
basically how long they want to be in
That's
an insurance network. Right, as long as we have that payer provider network model,
That's right.
that's the reason why they will be in. As soon as that financial model breaks, you would see a different behavior.
That's
Right?
right.
And there are, and to be quite honest, like, and I know about this was 3 years ago, I was kind of in that equation. There are folks who are working on an alternate model. Right, if you do the math, go to the economics of healthcare, right, there will be areas that will start getting pulled out. But right now, as long as, you know, and again, within providers, and I'm answering the question, what's this, right? But I think as long as providers, you know, depending on how they manage their pricing, depending on how they manage their chart of accounts, depending on, right? That right now, the relationship between the payer and the provider does cause, is the fundamental.
So really, simple way of saying it is it's an economic. Right?
Mhm.
What's the
Yeah, I mean,
incentive?
it's a symbiotic
What's the
relationship,
incentive?
right?
But, and right now, I'd say
But
that
for the provider, there really isn't.
there isn't one. In a fee-for-service world, you should be treating sick patients.
Right,
And you should be
right.
waiting for patients.
And I don't care about the rate.
So as the value-based arrangements change, right, to become more, you know, if providers have to start accepting downside risk, right? That's the incentive.
But the incentive will be,
Because at some point, they might not have the option.
But that's legislation.
Definitely, yeah.
There's no economic value.
yeah, I would say that pessimistically, the economic value is for the payer and the provider, and the providers will have to follow in suit because they start losing money. But a fee-for-service world, and a fee-for-service world, you want to treat sick patients, and you know, you actually lose money by keeping patients healthy because you charge less for an annual wellness versus.
We kind of hope that the volume should increase and.
Right.
So we do have another question from the chat, from Bob Dow. Are we going to have a problem with surprise bills and digital delivery like we have now with some hospitals?
In the case of,
I haven't been following it, so.
do you want to take the shot at it?
I did take an initial crack at it, and then go from there. So, I mean,
No, I'm saying I would hope, I hope not, but unfortunately, I think we'll have to figure out what the realities look like around that, because I think, again, we're broadening, right? We're broadening the arena, we're broadening the terrain. But I actually want to go back to that last question around connectiveness, because I think it points on something that Dr. Lau talked about when he talked about, you know, patients owning the data. And the questions around connectedness in legislation. I think that one of the things we realize, even with the delivery of telehealth, is that we still have a broadband capacity issue in this country, period. So we can develop the best technology, we can come up with the best tools, we can have the best, we can have the best of everything. But if we still have huge populations that can't access it, then again, we made something available but not accessible. So there's a great opportunity in terms of legislating. If we want to be able to create these opportunities for patients to really be able to engage, to be informed, and we're really thinking about the role of technology as our path forward, we have to make this broadband capacity a public health issue. Because if not, we're cutting ourselves off at the knees in terms of being able to help patients be actively engaged in their own healthcare experience. And they will never be able to own their own data if they can't access it, if it's spotty, right? So we can say, yes, we want them to own it, but we're not giving them the infrastructure, not putting around them the infrastructure that they need to be able to own it and understand it and access it. That's a legislative issue. And if we don't begin to think about it in that way, we won't move forward. But in terms of surprise billing, let's hope not, but unfortunately, I think it'll be something inevitable. But there are a whole lot of patient advocate groups like ours who are ready. We got our sleeves rolled up to take it on.
I think there's two things to touch on there. One is with the obviously the pandemic and the move of education into the home, right? Access to broadband connected is actually a public good, should be a public good, because you can't require children to be educated at home. I know education is not a topic we're taking on tonight, but children be educated at home and then not have access to that education. So it's not just a public health issue. I think it's a much broader issue that needs to be addressed. With regards to surprise billing, the question then becomes like what happens in hospitals if the anesthesiologist is an out-of-network group, even the hospital is in-network. If the telehealth provider or whatever carrier you're receiving is out-of-network and you're not aware of it, I think that's definitely potential. It begs the question as we move to a more telehealth model, right? And that's been more widely accepted in the last 18 months is if you're seeing a provider far out of your region because that's the only person available for the care that you need, or is the most immediate appointment available, will you have to pay for that care out of pocket? And how are you able to determine that provider group or that network is in network for you as an insured individual? So I guess it wouldn't necessarily surprise me to see surprise billing, but I wouldn't say the disappointment.
But I think you were trying to.
Oh, I just wanted to amplify that last point, and just riff on, I think, the analogy that Andy used earlier, which is, if you can draw the analogy between banking and healthcare, I don't often, if ever, walk into brick and mortar banks anymore. I take pictures of my checks and do a lot of stuff but I don't tell people I'm telebanking, I just bank. And I think that there will be a day on some way, in some form, that we'll just have healthcare that involves not in person. And when that day comes, if we haven't made gains in all the things we've been talking about, right, it wouldn't surprise me if there was surprise billing, because that will just be healthcare. We'll stop calling it telehealth as a special thing. But we need to fix all the things that we've talked about to avoid that.
I think we are getting a time signal, so I'll just do a quick round. Are there any other questions that we haven't answered? We'll probably take them afterwards. But quick round of closing comments. I think we'll go Andy, Dr. Winston, Shanta. Closing comments, Andy?
Yeah, I think we've touched on a lot of topics as it relates to coordination of care, but I think that's critical importance. What's going to drive it? What's going to really drive the innovation and the adoption and the exception or the acceptance of a coordinated care environment? I think we've touched on legislation, we've touched on shift in reimbursement. But like I said, I think at the end of the day, represent the point of view of technology. Technology is the tool that will allow for this to happen, but is not the solution. It cannot be done by itself. You can't give someone a piece of technology that will change the way that they interact with their patients, or change the way that they deliver care. It will give them the information to do that. And so I think critical in this equation is understanding that there's still always going to be services and therefore a human element in the delivery of care and the coordination of care across the entire healthcare ecosystem.
That was way too quick. I think my closing comment would be that I think we need the technology to advance to have interoperability, the inter-exchange of the data that's going across. I think the data needs to be cleaner that does go across, in that if you take 5 different payers, even though there's a standard format for all of these claims files that go across, you're going to get 5 different files that aren't going to work. So that in my mind is really the ultimate in terms of what's the key in terms of making care coordination successful. Once you have the data in place, I think Shanta said it the best at the very beginning, it's got to be patient-centric, and I still believe that every patient should have some degree of care coordination. In its simplest form, doctors looking and seeing what lab values have been going across, what services have been provided, no matter which doctor it is. Basically goes across the entire spectrum. But then once you put the patient in the middle, you determine what's preventing them from optimizing their health. Is it a social determinant? Is it access, is it maybe access to care? Or is it basically physicians not really truly looking at the data and trying to go and interpret it in terms of, what's the outcome that they should shoot for? So I think every stakeholder that deals with healthcare is a stakeholder in care coordination, and basically everybody needs to step to the plate.
That's what said. Joshua?
Great. Yeah, I think all of us probably here virtually or in person, think a lot about delivery models, systems, data, and it seems all very devoid of the human piece of it. I come away from this thinking it ultimately involves people getting together and making decisions about their health. And the reason I say that is because I think what we've heard multiple times, and I'll underscore my kind of closing comment here, is that data itself, a technology, a platform itself that's not the end. In some ways, it's actually just the beginning. In some ways, it takes you part of the way there. And so as we make advances, as we have companies and different stakeholders driving data solutions, to me, I'm looking for, okay, so what do we begin to do now? And we've gotten to the starting on what happens next. And I think a lot of that is systems, but systems in some ways are humans making decisions for large groups of people. And so I hope that we don't lose that part as we go forward in all these conversations. And I think whether it's the legislative side, it's the technology side, it's big, small, private company, et cetera, no matter what, if you think about those two things in parallel, I think we'll be all better off.
Thank you.
So mine is going to be short and sweet, and I think for me it's about remembering that we have to put patients back at the center of care. And I'm actually going to take something that one of my colleagues always says, which is it's not just about what's the matter with us, but it's also about what matters to us. And so as we think about care coordination, making sure that we're creating space for patient preferences, but also making sure that coordination, that we understand those barriers outside the four walls of our healthcare system that may be preventing individuals from being able to access and adhere to any type of care that we're trying to deliver.
Thank you. So I think in my closing comments, I'll just say it is a complicated topic. There are no simple answers. I don't think a perfect model has emerged. I don't think it's one size fits all. There is, all agree that there is going to be some uniqueness. We at Anthem say it's an individual one. There is a lot of work ahead of us. Keep the passion on. As you can see, the panelists are all very passionate about this. We all are, and at least for me, this is what I'm going to continue doing the rest of my life. I love this stuff. Thank you all. And Brian?
Thank you very much, Dr. Panel. Thank you very much, Dr. Panels. Thank you very much, guys. Again, I'd like to thank all of our event sponsor, from Anthem. I'd like to thank our society sponsors, and of course, thank you for all the work that the
Committee did in order to be able to get this set up. We do have 2 events coming up at the end of the year. We've got one in September and one coming up in November, and I have Robin, excuse me, Mary Beth speak really quickly about the September event here.
Thanks, everyone. Quick plug, September 23rd, it's a Thursday, same place, same time. This has been a great just to see everyone again. It's really exciting, the energy in the room. Really enjoy this. And hopefully you guys can join us on September 23rd. The event's going to be new and emerging technologies. So we'll talk about AI, we'll talk about blockchain, we'll talk about some other things, but hope you can join us.
Thanks, Mary Beth. And then we have an event in November. We actually just got this on the docket. We're going to be teaming up with one of our sister societies, the FinTech Society as well. And we're going to be doing emerging financial trends and technology trends in healthcare. Just want to make sure I got that one right. So obviously there's a lot going on from payment models and how that's changing in today's day and age. So definitely want to stay tuned for that one as well. We do have one other additional housekeeping item. We're trying to engage a little bit more on social media. We have both LinkedIn and Twitter accounts that we're now trying to promote. So if you do follow us, we're offering 50 tag bucks. Is that correct or not? Yes, I'm getting a thumbs up. 50 tag bucks. It can be used towards registration for next year. We'll do one that's going to be a new follower and one for an existing follower. So please follow us on Twitter and LinkedIn. Any parting thoughts?
Yeah, we have a Georgia HIMSS board member. Christopher, do you guys have any event coming up anytime soon?
The national conference.
Oh, of course,
It's
right.
coming up in Las Vegas in 2 weeks. The 9th through the 13th. First in person since the pandemic. Excited to be a part of that. Those of you who may be going out to Vegas. Definitely stop by the Juvenile Health Week. Come see us. We'd love to see you.
But also, you guys are hosting the Georgia chapter reception too, right?
Well, that's still up in the air.
Oh, okay.
I meant to call you today about that.
What about the DSS with you at 4 o'clock on
Absolutely.
Tuesday? And see who's there.
We are working on a reception. It's a little bit up in the air. The Georgia chapter did win chapter of the year. For HIMSS. And our chapter leader, Stephanie Brown, is our chapter leader of the year as well. So we have a lot to celebrate. And we are working on a public reception. There's a private reception. But we're also working on a public one. So again, for those of you who might be there, please stop by and visit us.
That's about it for us today. Thanks again to the panelists and all of our sponsors. So have a great evening.